Hello and welcome to the Rural Doctors Programme. I'm Jerry Gannon. Thanks for your company. This evening our programme focuses on cosmetic medicine, including both elective cosmetic surgery and the cosmetic considerations of more traditional areas of medicine. Elective cosmetic surgery is now well established, and increasingly you may have people coming into your practice expecting you to have a level of knowledge about cosmetic procedures and asking for your advice. So tonight we'll talk through as much as we have time for. We'll also investigate some of the non-cosmetic uses of Botox in muscle therapy, including its use in children and adolescents with cerebral palsy, as well as its use in urology. And we'll visit Dr. Fiona Wood to get her advice on how to minimize the cosmetic impact of burns. So let me introduce our panel for this evening's program. Dr. Olga Ward is back in the hot seat to lead our discussion tonight. Welcome back, Olga. It's been a while.
Thanks, Jerry.
And we're also pleased to have Dr. Rob Pearce, who's a plastic and reconstructive surgeon, hand surgeon, and Associate Professor of Surgery at UWA. Welcome, Rob.
Good evening.
And also with us is Dr. Glenn Murray, Medical Director of Absolute Cosmetic Medicine and past President of the Cosmetic Physician Society of Australasia. And Glenn also visits Kalgoorlie and Karratha. Welcome, Glenn.
Welcome. Thank you.
Now, before we begin, a reminder to you that this is an interactive program, so if you have any questions for Olga, Rob or Glenn, you can have your say at any time by giving us a call on 1-800-673-277 or 08929295241. So, Olga, plastic surgery, let's go for it.
Well, plastic and cosmetic surgery and cosmetic medicine. So, Rob, Glenn, welcome and thanks for joining us.
Pleasure.
Could you tell me a little bit about the differing roles of cosmetic surgeons and cosmetic physicians?
Shall I go first?
Yeah. By all means.
Well, as a plastic surgeon, my training has been broad, and most plastic surgeons do some cosmetic surgery, but very few concentrate just on that aesthetic part of the specialty. I think we learn to do aesthetic work on all parts of the body, and there are even total body lifts these days for people who've lost lots of weight. But essentially we like to keep a very professional standard and do the best for our patients in facelifts or busts and bellies, as we call them, and thigh lifts and that sort of thing. So it's a very broad scope.
Mm-hmm. And surgically focused, whereas
Glenn,
exactly. You're a physician,
yeah, that's
or
right.
a GP physician. What sort of things do you do?
Well, I guess we're the rapidly growing area that's evolved over the last few years. And really you could put it down to machines and needles. We do the cosmetic medical part of it, which is injectables and also lasers, etc. And especially probably the most famous laser-like machine in the last few years is the IPL, which has gone outside of the medical field as well.
Yeah. So you're mostly concerned with skin surface treatments?
Probably the skin and just below the skin.
Wrinkles and wrinkles.
Yeah, exactly, that's right. Probably we don't go down to the muscle that often, although Botox injections do go to the muscle. There are some facial fillers and injectables that do go down onto the periosteum, but probably we steer clear of the scalpel. Obviously we still do some skin lesions and things like that as well, but probably it's more the injectables and the non-scalpel type treatments.
I think what Glenn's pointing out is that beauty is not just skin deep.
Well and surely. So how do you go about assessing a patient's suitability for some kind of cosmetic treatment?
Probably this is the hardest thing. There's a lot of psychology involved in this part of medicine, and any conference you go to, you'll find a whole section in the cosmetic medicine or surgical conferences on body dysmorphic disorder and assessing the patient. Probably it's great when we do get some input from their general practitioner as to their suitability, and it's always good to get a letter along, although in our field we're a bit like the occupational physicians and the sports physicians. We don't need a referral, which is an advantage and disadvantage at the time. But probably a good, long conversation with the patient. History, like any part of medicine, is a great tool, and just a gut feeling and experience is probably a great way of assessing a patient's suitability.
Yeah. Rob, do you have any extra comments on that?
Yes, I'm pleased Glenn emphasised the psychological aspect. Not everybody is suitable for cosmetic surgery. There are other things to take into account, like age and overweight. Obesity is a problem, and there are a lot of people who have unreasonable expectations when they come to us, and as I say, they're not all suitable. I think from the psychological aspect, they need to understand what the limitations are.
Mm-hmm.
They all come very well informed these days because of what they see, and of course beauty is promoted in all their magazines and on films and in the media, and they all expect to look like Nicole Kidman or someone beautiful, but it's not sensible. But within those limitations we can advise, and there are very few, as Glenn pointed out, with body dysmorphic syndrome who are never satisfied, and we quickly sum up and turn those away because it's a waste of time, but it's also dangerous to start embarking on surgery for those people.
So I take it from this that you have actually declined to operate on or treat some patients.
Well, very definitely.
How do you go about convincing them maybe not to have a procedure or not to have a treatment?
It's very difficult, and you've got to be extremely tactful. And sometimes I think in my field is a little bit easier because you can divert them into a simpler time stalling procedures where you get to know the patient and you know how to broach the subject with them, that bigger procedures are not for them. You can also, obviously you've got the right not to treat a patient, but it's often kinder to explain why and be gentle and give them an ease out. And there are some patients that obviously do need referrals to psychologists or psychiatrists as well, although you don't really write a lot of those, but you can discuss it with the patient and tell them why you're doing this, and just realise that you've got to be fair to them as well.
As Rob was saying, the whole question of body image is something that particularly young women are very conscious of. What would you say to, what sort of things could a GP say to a young woman who doesn't need any cosmetic treatment? What are some of the lines that that a GP could use?
I have to say, Jerry, it's blokes as well.
Yeah.
There's no doubt
fair
about
enough.
that. There's no doubt about that.
Well, I think you can only say that you don't really need it, or wait until you do, or as Glenn was saying, you can distract them and say, well, this may not be what you're looking for. Let's try something else. As far as being able to turn people away, I think the easiest situation I can think of is somebody who's grossly overweight, and they're not going to benefit from, say, a facelift, and they're not going to benefit from having a lipectomy, which is only going to remove one roll of fat when they've got 20. Or you can suggest very rightly that they go away and lose weight and they'll get a better benefit. So the timing is terribly critical.
Would you ever tell them that they're actually going to look worse after it? Because there are some famous cases of people who don't look all that flash after having treatment.
I've not come to that, but I've often said you're not going to look any better.
Fair enough.
Yeah. What sort of preliminary workup would either of you expect from a GP if we're in the situation where we're referring a patient?
I think a really good past medical history obviously is great, but also a social history, and letting us know what they've had before in the way of cosmetic medicine and surgery, so that we see a great big long list. And it's a bit like the battle-scarred abdomen. We realise that we're the next person, and that maybe now something needs to be done and the issue needs to be broached, that they possibly maybe after the perfection that TV portrays to us, but they're not going to get there.
I don't know if I can afford to be terribly critical of family doctors, but I think they're grossly overworked and they don't have a lot of time to discuss the pros and cons of cosmetic surgery with their patients that they refer. But in the referrals, what I'm suggesting is that we might get a 2-line referral saying, here with Miss Jones who wants to talk about breast surgery.
Yeah.
Whether or not there's been any workup on that case, you can't tell from that letter.
But here with Miss Jones, who wishes to discuss breast surgery, who is on warfarin and epileptic, might be somewhat more useful to you.
Well, that's right, yes, and potential complications start there.
Mm-hmm.
We need to know that background. You'd be surprised how many don't include the medications or past medical history or even surgical history in their referrals. And I apologise to the general practitioners who are listening who probably do their very best to be comprehensive. If they are doing their job, though, they will give us every indication that this is a safe case to proceed with before we even meet the patient, or else what the pitfalls are likely to be.
Probably one of the best referrals that I've had was, this is a lady that's in for Botox and resurfacing, who has recently gone through a messy divorce. And I think that was where I thought there was an orange flag and we should slow down and chat.
Yeah.
I think what Glenn's hit on is a very important aspect of it, and that is the indications for surgery. People come in for all sorts of reasons, and mostly they want to look better. Young people want to look attractive to the other sex or to their partners, whichever sex they might be. But they want to look their best, and sometimes they want to copy glamour people in the media. They might all want to look like Jerry or something like that.
I doubt that, but anyway.
but I think they also sometimes make the mistake of trying to do something to save a marriage, to prevent a divorce, to please the husband or boyfriend, and these are all wrong. They've got to sort of understand that they're doing it for themselves, and what we attempt to do to change their appearance, which is what we're doing, is going to be permanent or semi-permanent until they get older anyway.
Yeah. So what are the really common things that you do? Say, Glenn, what would be the most common procedures that you would do?
Probably Botox is huge and has a very high brand recognition, and I think the thing that's important to note is I said brand recognition, because this is well medicine and it is well publicised, and you hear about it in the media all the time. So Botox is a huge thing that we do for wrinkles around the crow's feet and the frown, etc. Then there are the injectables. Everybody's heard of collagen, but it's actually moved on a long way from collagen, and Restylane is quite a well-known brand for plumping up lips and filling out lines and wrinkles, etc. But then there's also the IPL and laser machines for rosacea and redness around the face, for pigmentation post-pregnancy, etc. And so they're probably the big things, the injectables and as I said before, the lasers and the machines.
Is any of that rebatable, like IPL for rosacea, for instance?
Yes, it is. If you've got a vascular lesion that's considered severe and noticeable from 4 metres, then it is rebatable. It was taken off the PBS for a little while because it was so popular, and the machines got faster, and so you could do one in 10 minutes. So obviously a lot of people were doing them. But yes, there are quite a few things that are still in the book.
Yeah. And Rob,
Look,
are there
I'm
any
even
rebatable procedures
Well,
that
I'm
you
learning something here because I only saw IPL as being used for the permanent removal of hair and ageing spots and darkly pigmented lesions, but that's great, and I think the same applies to laser. It has a very broad use. From the surgeon's point of view, there are very few cosmetic procedures that attract a Medicare refund. In other words, they don't all have item numbers. The sort of things that do, though, are breast reductions and upper eyelid surgery, blepharoplasty. you can't claim on lower eyelids, or you can't claim on a facelift unless it's unilateral.
Yeah.
You can claim on correction of ptosis, which is a droopy eyelid, but that's an upper eyelid,
Yeah.
and it's a separate item number. Augmentations don't attract a Medicare rebate,
But so
some
breast reconstruction
reconstructions
after
do.
cancer would,
Yes,
yeah.
after cancer, yes. Lipectomy does, abdominal lipectomy, but liposuction doesn't. I think I'm right
In
there.
lipomas it does.
Yes, okay. Localised removal of fat. But there are a lot of things that have been scrubbed from the Medicare.
With the injectables, are there particular people who are not suitable for things like Botox or collagen? What are the things that GPs need to be asking their patients if they're seeking this treatment?
Oh, very good question. There's your psychological exclusions, but there's also your physical. Anybody on gentamicin, myasthenia gravis, anybody with a significant neuromuscular junction dysfunction should avoid Botox. Obviously, pregnancy.
Gentamicin?
Yep, gentamicin can increase the duration and it can make Botox more unpredictable. And also obviously breastfeeding and pregnancy, which is of concern for us because there are a lot of girls that have Botox, consistently and will not know they're pregnant. So it's something that we do actually mention and have on our consent form saying, and we often will ask them, are you pregnant? How are you sure? Just so we make sure that we don't go and give them Botox while they're pregnant.
What sort of impact can it have on the fetus?
Well, it's a theoretical thing, and it's like a lot of things in medicine. It hasn't been completely established. In mice, it causes an increased risk of miscarriage in the first trimester. In humans, though, probably it's not anywhere near as severe because there'd be so many girls that would have had it actually when they were pregnant, as they would have had a lot of other things.
All right, I think we might take a break there, Olga.
Okay.
And our first video segment tonight looks at the therapeutic uses of Botox. And we spoke to urologist Dr. Jeff Thavalisan from Royal Perth Hospital about his ongoing research and trials using Botox, and also to Dr. Jane Valentine from the Paediatric Rehabilitation Unit at Princess Margaret Hospital, where they're using Botox in the treatment of spasticity.
Botox was originally described in 1820 by a physician, Justinus Kerner. He investigated some deaths from sausage poisoning in a town called Wittenberg. And it was due to botulism, but what was interesting is he thought it was the fat content of the sausage that killed the people, but he wrote this monograph, and in the monograph he mentioned that this substance, whatever it could be, would be used as a therapeutic tool in the future. And I find that amazing so many years before that it could actually be recognised as a therapeutic tool. Its use has actually expanded since about 1998. Firstly, we can use it for patients with neurogenic overactivity. So these are spinal injured patients or patients with multiple sclerosis or other neurological conditions, and they have an irritable bladder. So the bladder fills up and then it squeezes out the urine on its own accord. And basically the Botox calms the bladder down. Since then, we've been using it for patients who haven't got spinal cord injury or neurological conditions who have an irritable bladder. That's still being investigated. We're using it in patients who have some kind of pain syndrome associated with the bladder. And more recently, we're looking at its use in prostate disease as well. So it's got a wide variety of uses that are being investigated at the moment in urology. The mechanism by which Botox works is two ways. One, it actually relaxes the bladder muscle, and it does that by stopping the nerve signalling to the bladder muscle, so it stops the release of the transmitter, which is called acetylcholine. But it also has an effect on stopping the signals going from the bladder to the spinal cord, and that's why it also works in other areas of the body for migraines, which is a pain syndrome. So it has two mechanisms in the bladder, and once you put it into the bladder, and we do that by way of injecting it into the bladder wall, it can last for anywhere between 6 to 12 months, and it needs repeated injections. So the actual procedure involves either a light anaesthetic or sedation. We do a cystoscopy, have a look in the bladder with a telescope, and do multiple injections into the bladder wall. If I'm using 3 vials of Botox, I would use about 10 mils mixed in each vial, so a total of 30 mils, and we would spread this out throughout the bladder. So usually the injections are about 1 mil each, and we put the needle into the bladder wall and inject it. The main risks after that are the patient may have a bit of hematuria, so pass a bit of blood up when they pass the water, and there's a risk of infection, so we cover them with antibiotics. If you can imagine, we're shutting down the bladder in terms of its ability to squeeze out the urine. In a person who has an irritable bladder and we put in a maximum dose, they're not going to be able to pass water naturally after that. So if we use a full dose, they need to empty their bladder somehow, and these patients then self-catheterize. They use a catheter to empty their bladder every 4 or every 6 hours. In patients who haven't got a spinal cord injury or a neurological condition, and you just want to dull the bladder a little bit, we can use a lower dose of about 1 vial, 100 units, and that could just suppress the irritability but not stop the muscle working, so that they have some ability to empty their bladder. But like I said, this is all still in investigative sort of phase. We're trying to still work out the best dose and the best method. So if you were thinking of referring a patient for the use of Botox, firstly, if it's a neurological injury or neurological condition such as MS, places like Shenton Park specialise in neurourology, and we would see these patients, we would assess them and do some tests like urodynamics and ensure that their bladder fits into the criteria, and so we're trying to diagnose what's called an overactive bladder. Initially, we'll trial them on conservative treatment, and this could include tablets, various medications known as anticholinergics, and if that's not effective, then we would consider them for use of Botox. Now, you need to be aware it's not readily available. It's available on a research trial basis at the moment. We can get special permission through the health department to use in certain cases as well. So the aim is over the next 12 to 24 months it will become more readily available, but we need to obtain TGA approval.
At PMH, in the Department of Paediatric Rehabilitation, we have what's called the Cerebral Palsy Mobility Service, which is set up and funded to manage all the mobility issues in kids with CP. They certainly still need their community providers like Disability Services Commission or the Centre for Cerebral Palsy, but we address the tertiary medical issues of their mobility. The majority of kids with cerebral palsy have a problem with spasticity, and the reason we want to treat spasticity is that it blocks function. And the other issue is that spastic muscle doesn't grow normally, and it doesn't grow as normal as bone. So if you don't treat it, because obviously the big issue for these kids is growth. Their brain condition isn't progressing, but they're growing. So we're trying to manage the spasticity through growth. Botulinum toxin works by being injected intramuscularly, and it works by therefore reducing the spasticity in the muscle that you inject it. So, and the amount of reduction in spasticity is dose dependent on how much you put in, and it's injected and taken up by the neuromuscular junction, and it blocks the release of acetylcholine, so it's dose-related weakness, and it also feeds back and blocks the sensory arc, so the spasticity reflex, so it's actually decreasing spasticity that way. That gives you better function, gives you better biomechanical correction, gives you better power, and you're using it to therefore improve function and decrease your complications of growth and spasticity. So for a group of kids with mild disorders, you will decrease the need for any surgery. For others, you will delay it. And for those that were definitely going to need it, you will improve them prior to the dates of surgery. This is an older adolescent girl who has a hemiplegia and has a left congenital hemiparesis, and you'll note her arm's involved as well, actually, in a gait. And she strikes in a gait with her metatarsal heads. 5 weeks after botulinum toxin, you see that she's achieving heel strike in gait. She had injections to hamstrings, to the left hamstring and the left gastrosoleus. So she's got a much better knee movement and much better heel strike and power. So she's had a good response, and she's a girl who's had a large series of botulinum toxin injections over many years. We use it in conjunction with other programs. So you have to be in a community service with physiotherapy, you have to have access and have compliance, because it really is an adjunct treatment. It doesn't work on its own. You need it in conjunction with physio, quite often with splints and with strengthening programs. And after 3 months, the drug itself's gone, the nerve endings re-sprouted, and it's re-secreting the chemicals. So the spasticity comes back. What you hope is that your clinical effect lasts at least 6 months, because in that period of time you've biomechanically corrected them, you've been able to use it as an adjunct in your therapy program, and you're decreasing your complications as they grow. This is a video of a delightful little girl who was referred to us at 18 months as a girl with monoplegia and who had spasticity and had a fixed contracture of her gastrosoleus muscles. She has really beautiful power, she has very good sensation, she has very good motor control. Her leg does what she wants to do. The single biggest issue influencing her gait is purely spasticity. She came to botulinum toxin, just injected into the gastrosoleus muscle. She came in, she had MLAR put on her skin, she had some midazolam, and then we injected it in intramuscularly, and we've obviously brought her down very nicely because we've created some weakness and reduction in spasticity in that foot. Now, the issue is if we don't do anything, spasticity, the drug's going to wear off, the spasticity will come back, and the problem will continue. So the aim then is to intervene with strengthening and splints that will hold her foot during growth in a better position and ensure that the carryover effect is continuous. Now here she is at 8 months, and she's maintained her effect, and she's got local physio, she's got splints, and she's got ongoing access to botulinum toxin. We now use this a lot in the upper limb in children. There's been a large number of trials, some that we've done through here, and it's about to be licensed in children in the upper limb, so sort of symbolic that it really does have a role. I think this boy's between 3 and 4, and he has a congenital hemiplegia. He's a very bright little boy. He's got a right hemiparesis. You can see he's got quite marked fisting, he can't grasp well, and his whole body moves as he moves his hand forward, and he can't isolate his fine motor movements there. This is after botulinum toxin injections, and this boy had his wrist flexors injected, his biceps brachialis, and his pronator teres and pronator quadratus injected, and his adductor pollicis. And he's got much better grasp, much better release. And you'll just notice the whole of him's not moving as he attempts to use this, and he's spontaneously using this arm more. Cerebral Palsy Mobility Service has a cerebral palsy liaison officer and it has an entry clinic so that if there's any children that you consider are eligible for botulinum toxin, or who in fact you realise have CP and may well be lost to resources and certainly to any screening systems, this is you're most welcome to refer them down to us, and our liaison officer will track them and re-enter them into all the appropriate systems. So it's quite easy to enter into the system, and our agenda has been to attempt to find all kids with CP and to ensure they have access to eligible services.
Thanks to Dr. Jeff Thavasilan and Dr. Jane Valentine, and we were just discussing here in the studio that there's some pretty impressive results when you see it there on the screen, isn't there?
They're just fantastic.
Yeah, absolutely, yeah. Brilliant.
Mind-blowing.
Before we go back to our discussion, a reminder that if you'd like to call us at any time, if you've got any questions or comments, please give us a call. The number is 1800 673 277 or 08 9229 5241. Before we move on to talking about scarring, a couple of issues we were discussing during the break with Botox.
Yeah, Glenn, Botox injections that patients have for cosmetic treatment in the face, I guess not nearly as huge or as many muscles as the kids.
No, that's right. I often say that to the patients that do get a little bit concerned about the toxin issue, that in the children it's about 100 to 300 times higher. It's actually quite high, and they do have it over an extremely prolonged period of time. So it sort of implies that the facial Botox is quite safe.
Now the kids are having it every sort of 3 to 6 months. Is that the same for the cosmetic procedure?
Exactly. Botox is 3 to 6 months. It can be variable. Some people get 1 to 2 years out of it. That's not common. When you talk about it for the use of sweating in hyperhidrosis, it's fascinating. Some people can get up to 2 years, and in fact, on average, you get longer out of the effect of reducing the sweating. You get around 6 to 12 months instead of 3 to 6 months, and no one really knows why.
And that's not a neuromuscular thing?
Well, yeah, it is. Sweating is it still blocks the nerve that innervates the sweat gland, so it's still a neuromuscular junction inhibition. So.
Is there any difference in the physiology of the sort of the kids that we saw on that video insert and adults in terms of how their body works with Botox?
Well, not really. It's a muscle in the leg that's too tight and is causing deformities, and in the face, it's a muscle that's as we get older, the skin is not fighting against, so you're getting more wrinkles.
I guess I was talking more in terms of how Botox breaks down in the body. Is there any difference between children and adults?
There are physiological differences between children and adults in other things, but not so much in Botox. Both break down over 3 to 6 months. They're taken up by the nerve terminal. They jump onto SNAP25 protein, that's the theory anyway, and then over 3 to 6 months it breaks down, and the nerve there's two theories on it. The nerve either grows little sprouts around and re-innervates, or actually the nerve ending starts working again because it's got that new chemical that's been formed.
If I use Botox to get rid of all my wrinkles, I'd like to kind of keep it that way.
We don't have enough.
This means long-term use of Botox. Are there health implications of long-term use?
Well, with children especially, Botox has been used for a long time now, and probably the thing that I like about Botox, even though you mentioned the name and people do get a bit uptight, is that even the side effects are short-term. It's fascinating that the Botox can smooth the forehead for 3 to 6 months, but if it does migrate down into the eyebrow and give you a ptosis, it's only for 2 or 3 weeks. So even the side effects are short-term. As was mentioned before, there is some slight concern because it is mixed with albumin, depending on which brand that you have of Botox, and there is concerns regarding blood-borne products. But on average, Botox is an extremely forgiving product.
Then I was interested, you mentioned hyperhidrosis, and I'm mostly thinking about patients with axillary hyperhidrosis, but can you use it on patients with really sweaty, drippy palms as well?
You can. In fact, it's extremely distressing for young men, but also if they're tradesmen. And you can use it in the hands. You've got to be a little bit more careful because they can get muscle weakness. But this is an intradermal injection more so in the hands because it's the sweat glands. So you can do it there, but it does hurt a bit, so you need some MLR.
And Rob, you don't use Botox at all?
No, I've got no experience with Botox. From the hyperhidrosis point of view, we still occasionally operate on those, and it's a matter of excising all the hair bearing, and that happens to be the glandular sweat gland tissue in the axilla. Mind you, that in its own way leaves a scar, and it might be a good segue to lead you into a discussion about scarring.
I was going to say you're the man to ask about scars. Could you comment about treating, particularly things like keloid scars, which are often quite a bit of a problem for the patients?
Yes, and they occur in certain skin types, especially people with pigmented skin, and others. And of course, they're a real red light if you're aware that people will react with this type of scarring to avoid further surgery, because it's certainly not cosmetic. There are several ways of treating keloid, and surgery should be the last resort, because very often it just makes the situation worse. But the easiest methods are pressure and injection with a synthetic steroid, triamcinolone or something along those lines. They're sometimes very difficult to get rid of, especially the nodules in earlobes where people have had their ears pierced. They're keloid. But it's important to make a distinction between true keloid and hypertrophic scar, which is a self-limiting lumpy scar that, as I say, self-limiting, it gets better on its own to some extent. There's a certain amount of resolution over time, and they do get flatter and softer, and the colour changes over maybe a period of years. But the true keloid keeps on growing. It's a progressive growth, like a benign neoplasm.
Yeah.
And I find the best treatment is probably pressure with silicone strips or injection, and that's an art in itself. You have to inject an undiluted amount of triamcinolone directly into the scar tissue under pressure, and maybe repeat it in a month's time, sometimes even two or three times, excuse me.
Yeah. So, you were talking about silicone strips. Is that like those scar-reducing dressings that we see coming out from Johnson & Johnson and whatever that the patients just put on anyway?
They're pretty similar. You can get them from a lot of pharmacies, although there was a study done that showed that there was no difference between silicone strips and actually Fixamol or Mefix.
Yeah.
And so any type of pressure, as Rob mentioned, any type of pressure at all is beneficial. You can also use, I actually try to steer clear of keloids for this, but you can use for hypertrophic scars, IPL and pulse dye lasers, etc. And usually more than improve it, more than Father Time will improve it, it speeds up the process of getting rid of the erythema out of the scar, which is often what people don't like. They want it to be flatter and not as red.
Yep.
So there are a few things that you can do.
This wouldn't work on a keloid? So like I've got a patient who had a rubella vaccination, she's got an enormous keloid.
Pulse dye is reasonably successful, but it has, on the other hand, it has quite a high failure rate with keloids as well.
What about the use of things like vitamin E cream on new scars to heal them?
Well, I don't believe vitamin E on scar tissue from an external application has any effect whatsoever, and I think it's a waste of money. If you have a big operation where there's a lot of scarring, say across a belly or an abdominal scar, then I think probably the progress of the development of the scar tissue can be limited to some extent by using oral vitamin E as an antioxidant.
In what sort of quantities, Rob?
Just a large capsule about the size of, I don't know what the dose is, but it's the size of a jelly bean. You take it once a day for about a month.
1,000 milligrams or something. Yeah.
Something like
What are some of the other myths that, while we've busted the vitamin E cream myth, are there other myths around scars that you can bust?
Well, I think something we're going to discuss in a short while, the myth about having scarless surgery and scarless burns is probably the biggest myth. I don't think it's possible, and it's, while we'll give Fiona Wood her due in trying to achieve it, it's an aim that's unlikely to be possible.
I'll let you moderate that argument between Rob and Fiona.
You can't
Wood.
injure the skin without having a scar,
No,
I don't believe.
Minimise harm. When you were talking about vitamin E as a cream versus a capsule, I'm reminded of a recent episode of Gruen Transfer where they were talking about all sorts of interesting extracts that one could smear upon one's face, including placental extracts and rat urine, for all I know. Does the skin actually absorb anything?
Yes, it does. This is quite sad, really, because a lot of the rubbish actually hides a few good products. Retin-A, which is Andifrin, which we all know is a topical anti-acne treatment, is actually quite good for rejuvenating the skin and reducing fine lines. And it's absorbed. Alpha hydroxy acids and their later cousin, the beta hydroxy acids, are also absorbed and are rejuvenating. And there's two ways they do this. One is from a straight irritative acidic way of taking off the top layer of the skin and stimulating the skin to grow, but there are also supposedly some second messengers that are getting down to the collagen layers and a bit deeper to stimulate growth. And you do notice, I noticed it on my wife's face, she's a Geraldton girl with a bit of sun damage, and probably in the last 10 years her skin's improved, not gone backwards. So some things do work. It's just a shame that you don't hear them in the advertising as much.
As we all know, a lot of drugs these days are being incorporated into patches like hormone replacement and the nicotine patches for quitting smoking. But the vehicle that penetrates the skin, as far as I understand, is the finest oil, and some of the finest oils are whale oil and emu oil. And so we're on a good thing in Western Australia because emu oil has a real future.
What about repairing surgically, Rob, old scars? Say if somebody's just had a scar for years on their neck or their face and they've finally decided to do something about it. Does the age of the scar determine how successful getting rid of it is going to be?
It certainly does, and if you have a fresh scar, you'd prefer to leave it for a year or 18 months until it's matured before you go back and make a new one. On the other hand, a lot of patients are very impatient, so they're crying out for something to be done. What does have an impact is the age of the patient. Older people like myself will form very good scars, whatever you do, as long as they're placed properly, and that's where our expertise as medical practitioners come in. We hope we know the best place to make the cut and the right direction. You don't cut across the grain, for instance, in the neck. You go in the creases across the neck for a thyroid operation, and they form really good fine scars, and the older the patient the better, because that skin has lost its elasticity, and that's one of the things that causes big changes. And again, we'll come into another area that you want to discuss, I think, Olga, like stretch marks. Young ladies who expand too quickly with their pregnancies develop stretch marks because those areas have destroyed elastic levels in their skin, and it can't be replaced. Well, I don't think it can be replaced, but some people might have a different
Glenn might have a hot
attitude.
tip for that one.
But I don't think it's possible to reverse some things, and certainly you can't easily reverse the changes that take place with ageing.
So, something to look forward to as we grow older.
That's it. Well, Glenn, do you have a hot tip for stretch marks?
Well, there's been some interesting research in the last year regarding two lasers, 1064 into YAG laser, and also the new fractional lasers, which are sort of the hot topic in a lot of cosmetic medicine at the moment. And the 1064 basically selectively heats the striae region to stimulate collagen growth. And the results are reasonably effective. It was quite amusing in the study because for once the doctors didn't think it worked as well, the patients thought it worked very well, and the histologists thought it worked the best. So for once the gold standard of histology was actually in their favour, which is great because it's some things in cosmetic medicine and surgery it's not always. The other one, the Fraxel lasers, probably or Pixel, there's two brands that you can find, are very interesting. They punch little holes into the skin. Now, they're developed from the days of resurfacing we used to burn the skin off for scarring, etc. These punch holes in the skin and heat the skin and cause micro damage so that you get growing in of collagen, etc., and an improvement in that area. So there are some interesting things on the horizon. And as we all would know, if you could get rid of stretch marks, you'd buy the small island of Bermuda yesterday. So.
That's it. You've talked about lasers and Botox, and I noticed that there are plenty of non-medical practitioners that seem to use IPL and lasers and Botox. How are those kinds of things regulated? Because, of course, we're the ones they come to when it doesn't work so well.
Yeah, probably something very important for all doctors to know, and especially general practitioners, is that a little bit of a loophole in the regulations has allowed some cosmetic medical machines, especially IPL, to be sold to non-medical people. And it's a bit of a hobby horse of mine, and I smiled when you asked me about it. But I think it's very of big concern because these are machines that can cause burns, etc., hyperpigmentation, and more seriously, permanent hypopigmentation. And I think it's time to get them back into the medical field and at least have doctors supervising it. I think skin cancer now has gone through the roof in this country, and that people are getting spots burnt off left, right, and centre, and we don't know what they are. And these people don't have any qualifications to diagnose a melanoma versus a superficial BCC. So I think IPL, it's if you've got a patient that said, well, who shall I go to? Just tell them to go and see a doctor with experience.
Yeah.
I'm sure Glenn would agree that we see a lot of the problems, the complications that come out of these treatments, and sometimes it's hopeless trying to patch them up. One of the old treatments for keloid, just going back before your time, Olga, would be that they used to recommend radiotherapy for keloid scars, and of course that's a no-no now. We wouldn't ever use that, or I don't think we would, but it's not recommended because of the potential danger of irradiation to the skin.
Yeah.
And the danger isn't just skin cancer, but you can make a worse thin scar with no pigment, as Glenn was saying, with some of these other treatments, which will show up even more than the lump.
Yeah. And just quickly, one of the things that my patients, which I just thought of, find perhaps most distressing, the patients with enormous numbers of things like neurofibromas or seborrheic keratoses, and particularly the seborrheic keratoses when they come in their hundreds in older age. Does either of you have a really great treatment for them?
IPL is great, but you've got to tell the patients that they can come back and they probably need to have it again. But IPL is extremely good, especially if they're well pigmented, because it's very selective. It has selective photothermolysis, so on average it will leave the normal skin alone. And where the little footprints of the seborrheic keratoses go down, it will actually selectively cook them out. So IPL is quite good, but once again, you know, they're going to need another treatment in the future.
This is one of the areas, can I just have a minute? This is one of the areas where I think general practitioners can play a very big part, and it'll sort of relieve some of the humdrum of family practice if they feel it's a procedure. I shave seborrheic keratoses if they're in areas that are irritated or causing problems because they're on the face or somewhere where they're unsightly. And you can do that under local anaesthetic, flush with the skin surface, and not leave a mark. It fades like an abrasion, and it just looks like normal skin colour. But again, as Glenn suggested, they can grow back over a period of time. But you can do the same again. If you're going to do something like that, it's like any sort of curette. You send your specimen away and have it examined histologically to confirm the diagnosis.
To stop bleeding, you just
put a dressing on.
Well, our final segment tonight is an interview with Dr. Fiona Wood, head of the Royal Perth Burns Unit. Dr. Wood gave us her advice on how to minimise the cosmetic impact of burns at each step in the treatment of an injury, starting with preventing the burn in the first place.
Everyone in the community has a role in prevention, but there's nobody better placed to look at secondary prevention than a GP. You see the injuries as they come through your door, you know the people, the circumstances, and that gives a very unique opportunity to actually look at the circumstances and prevent someone else in that family having the same injury. Every intervention from the point of injury influences a scar worn for life. If there's no injury, there is no scar. And it's a really hard thing to measure, because if it doesn't happen, would it have? But when we started here in the city looking at our prevention programs and our awareness, it is clear that it can influence the numbers of patients we see. So prevention does work. It is difficult to measure, but it can be measured, and the end result is much better for everybody. No scar, no work. The understanding that first aid can make a real and tangible difference to the scar worn for life and the cosmetic outcome is really important. We know from very good evidence that if you cool the burn wound between 15 to 18 degrees cooling, no ice, ice will give a cold damage on top of the heat damage, so you avoid anything too cool. But that cooling will actually transfer the heat from the surface of the wound and away, then you will reduce the damage. You will reduce the damage by 80%. And that is really very, very powerful, because from our work, reviewing and understanding which patients come to us who've had first aid and who haven't, we know that our incidence of surgical intervention, because the wounds are deeper, is greater in those that haven't had first aid. So first aid is a really very useful tool, and it's simple. 15 to 18 degrees cool water, and the cooling has to keep being removed. Cool running water is ideal, but in those circumstances where that is difficult, changing the surface cloths have to be done quite regularly, certainly once a minute, because you'll feel the cloths on the surface get warm. If water is in short supply, can you cool the wound by using water in aerosols, in plant sprayers? And the answer is yes, and you get a more effective cooling for less water. If the source of water is contaminated, then we're in a really difficult situation. If you jump into a dam, for instance, you will cool the wound. But will you put that person at risk of infection? And in those circumstances, making sure that everyone knows about it, making sure that the person is very well washed when they come in is really important to reduce that bacterial load. And in some instances, sending a sample of the water with the patient so that they can have a look and see if there's any problem with it. When you look at first aid, it really has an opportunity to change the health budget as well, and to change the interventions required for the individual and for the whole community. Because if you can imagine, by changing the burn wound with first aid by 80%, then that is a really tangible funding difference to the health system down the track. From a child who doesn't need surgery, who won't need pressure garments, who won't need secondary reconstructive surgery when they want to go to the school ball and won't need that plastic surgery, that is a huge difference to that individual, to that child, a huge difference to the parents of that child, and a difference to all of us, because that is funding that could be used elsewhere. One of the most difficult things about burn injuries is assessment. If we could look at a burn patient and right at the very beginning and say, absolutely with 100% surety, that burn wound will heal in 10 days, all I need to do is dressings, then it would be very simple. Unfortunately, it's not that easy. The ability of a wound to heal depends on many factors. It depends on the individual. What capacity has that individual got to regenerate that and heal that wound? What are the factors within the wound? Whether it's the dead tissue, whether it's bacterial load, and the actual cellular capacity within the wound. Is the patient diabetic, elderly, young? All these different things will influence the way that wound will heal and will change over the first few days. So assessment is really important. We assess burn wounds in terms of the depth of injury, how much is injured, and how big an area is injured. And there are certain criteria where we would absolutely say this person needs specialist help. For example, a larger surface area, over 10%, will need an intravenous drip establishing and transfer to control that resuscitation. A burn wound that is full thickness, or on the face or the hand, will need specialist attention. But they're actually not the majority. The vast majority of burns are relatively small and not so deep. And so to make sure that you give the best quality of care and understand that every single intervention, all your care, will influence the scar and the cosmetic outcome, it's key that you reassess. You assess to begin with and ask that question. Keep asking the question, will this heal in 10 days? If it heals in 10 days, the risk of a significant scar are less than 4%. And I think the dressing systems which allow you to look at 48 hours and then subsequently at another 3 to 5 days later than that are the ones to ideally use. Whether that's an alginate, a hydrocolloid, all these, there's many, many different ways of doing it, but you want to be able to look at it in an atraumatic way at about 2 days, about 5 days, to just be sure. And you can't often predict what it's going to be like in 48 hours without actually looking in 48 hours or 5 days, whatever may be appropriate with the dressings that we use. When you look considering the burn and reviewing the patient, making sure that they keep functionally, keep moving. If it's a hand, elevate, but keep it moving. Make sure they've got adequate pain relief in those early stages. And you come to the point of maybe 5 days when you think, well, I'm not sure that burn will heal in another 5 days and maybe that surgical intervention is required, then I think it's contact either the adult or the children's unit, and we will organise the transfer into the hospital so that we can then take them down that more intensive pathway. Subsequent to that, as the patient heals, of course they have to come back home, and then the scar management continues. We try and consider the scar outcome at every step of the way. The dressings we use, the surgery we use, and now post-surgery, how do we look after that surface? Advice on massage, sun protection, pressure therapy, the topical scar sheets, such as the silicone-based scar sheets, all play a part in actually improving the quality of that scar. And I think through education and communication, the GP has a significant role in that, and that can actually influence other areas of practice. Post removal of moles or anything, you can improve the quality of the scar by local therapies. Every intervention influences the scar that is worn for life. I think there are times that are pivotal in the burn wound. The initial assessment will really dictate what you do. The reassessments, again, give an opportunity to make sure that you're on the right track. Are you on the right track? Can we help with that decision? When a patient comes closer to that 10-day time frame, is this path the right path? Do they need a surgical path? As the patient returns home after intervention or returns back healed without intervention, what can we do then? Can we optimize the scar and reduce that scar that that person wears for life? And the answer is yes. And we're here at any stage, all those stages, to offer advice and help where we possibly can. We're just a phone call away at Royal Perth and PMH Hospital Switchboard.
Dr. Fiona Wood there from Royal Perth, and a big thank you to Fiona for making herself available to the programme. Well, that's all we have time for tonight. Any final take-home messages, guys? Rob, Glenn?
Well, I'd like to emphasise to practitioners in the rural sector to not necessarily ignore cosmetic surgery and let the patients pursue their goal to have something done, but at all times refer them to specialists who they know are experienced, and I think that's terribly important.
Yeah. Glenn, how about you?
Yeah, I agree. I think it's good to forget about the taboos of cosmetic medicine, take it seriously, and I think the patients will appreciate you for it, really.
Terrific. Now, don't forget, if there's any part of this program that you'd like to review at a later time, a delayed transmission of the Rural Doctors program will be available via internet web streaming next week. And this service is accessible through the Rural Health West website at www.ruralhealthwest.com.au. And do note that the internet transmissions are password protected, so if you haven't already, you'll need to register by contacting Rural Health West. And also a reminder that the broadcasts are now available for download from the Rural Health West website as either video or audio only podcasts, so you can download the programs and listen to them at your office or in your car. You wanted to talk about evaluations?
Yes, we're hoping to get some ideas from the doctors as to what they would like to see in this program, what things they'd like to know more about, and any things that they think aren't working quite so well. And if you have brilliant ideas, then there will be some questionnaires coming out to you. Please fill them out. If you don't tell us what you want, then we won't be able to provide it for you. And I think the questionnaire will come out with Rural Health Matters as well.
Terrific. Okay, we look forward to that. Now, if you have any questions about registering for the podcast, just call Rural Health West on 08 6389 4500. We're back on the 7th of October with a program for you focusing on some of the medical implications of working closely with animals. That's been in the news lately. We look forward to your company then. Thanks again to our studio panel tonight, Dr. Olga Ward, Dr. Rob Pearce and Dr. Glenn Murray. And thanks to you for taking the time to join us. Good night.